So we're going to talk about the use of intraoperative radiotherapy in the abdomen and pelvis. And I was talking to one of our surgery colleagues at the break, and intraoperative radiation to me is a lot like hyperthermia. We know it works, but if we don't have it, we forget about it. And we know intraoperative radiation can help in a lot of clinical situations in the abdomen and pelvis and other sites of the body, but it's very difficult for most of us to give. I give an example. The last time I did pancreatic IORT at my last institution, we would take the patient open under anesthesia, roll them 4 blocks across into the basement, put the electron tube in, treat, and then the patient had a really bad bleed, and that was the last time we ever did it. So we don't do it because it's hard. It's hard to do. It's practically hard to do. Most of us don't have an operating room with an accelerator. If you do, it ties up your room for a long time. In this day and age, it's hard to do. So to me, intrabeam is one of the ideal situations to use this for is in these situations. So a lot of this talk will simply be talking about previous IORT data and reminding people that there is some data that, and especially in advanced and recurrent disease, this can really have an impact. So we're going to talk about a little bit of introduction, IORT, data supporting the use of IORT, and some of our experience at Loyola University. So we know the use of external beam radiation can be limited by treatment with sufficient conventional doses while meeting normal tissue dose constraints. And even in the era of SBRT, this is still an issue. And intraoperative radiation is a technique employed to overcome these limitations while delivering an adequate dose to the tumor. And there are really 2 major uses of IORT in the abdomen and pelvis: intraoperative electron beam, IOERT, either done by a linear accelerator or a machine like a Mobitron, or high-dose rate brachytherapy are the 2 main ways people have done intraoperative radiation. I did a couple low-dose rate intraoperative radiations in the past, but the catheters always get messed around and it wasn't very good. So IORT has a long history of being used and can be safely given in doses of about 10 to 20 gray at the time of surgery. Animal studies on dogs by Sidler et al. Showed few growths for histological abnormality at doses of about 20 gray. While the biological effectiveness is not completely understood, it's estimated to be about 2 to 3 times a conventional fractionation using the alpha-beta ratio. But that's where we need to accumulate more data when it comes to the intrabeam device, because we know the RBE is higher, and we know the dose is much different than electrons and much different than high-dose rate brachy, and it's things we just need to learn and what we can give safely and what the right doses can be. But where do we use IORT? You name it, you can use it. I've used it in pretty much every abdominal pelvic malignancy we treat for recurrent or advanced disease. So let's just go briefly over some of the data on IORT, especially for the surgeons. There's a lot of data on the use of IORT, not obviously with intrabeam. This is some data on using it in locally advanced and recurring esophageal and gastric adenocarcinomas. I won't bore you with the data, but basically there was no patient had progression in these IORT fields. So a lot of times we don't use it because we don't get to the OR, but I've been called more than once the day before a procedure saying, hey, we might want to do it in this patient. Again, using intraoperative radiotherapy combined with chemoradiotherapy for localized or advanced gastric adenocarcinomas, and again, a suggestion that adding IORT to conventional radiation improves local regional control. Pancreatic cancer. I've given BORs and GI before, and I don't even ask pancreatic cancer patient questions for radiation oncologists because we don't know what the role is. We do know there's one thing we should do with anyone who has pancreas cancer, and that's put them on a trial. So I do think we need to look at different ways to do things, but as we improve our systemic treatment of pancreatic cancer, local control becomes more of an issue because how many patients are cured from cancer if they don't have local control? That'd be 0. So it does become an issue if we can get better systemic agents. And there's a lot of data on intraoperative radiation for pancreatic cancer. This is just some of it. External intraoperative radiotherapy for resectable and unresectable pancreatic cancer. A lot of it comes from these same authors in Japan. And again, just suggesting that the performance at IORT was thought to be a significant prognostic factor. Another multi-institutional review, again from our colleagues in Japan, talking about using it for unresectable disease. Again, relatively favorable local control for unresectable pancreatic cancer. And again, this is another one for looking at different institutions, and again, showing excellent local control rates by the addition of intraoperative radiation. We just stopped doing it because it was difficult. This is a case report that Dr. Holford did the surgery, and we collaborated on the case report. It got published, I think, in Frontiers this week. We just talked about the role of intraoperative or intrabeam in pancreatic cancer. This is a 50-year-old man who presented with 2-week history of abdominal pain. CT scan revealed a significant lesion in the region of the uncinate process, contacting 50 degrees of the mesenteric vein. You can see it in that picture. Underwent neoadjuvant chemoradiation with protracted effusion of 5FU and involved field dose to a dose of 50.4 gray. Had a good radiographic response. Was taken to surgery and underwent a pylorus-preserving pancreaduodectomy, and a boost dose of 18 gray was prescribed with the surface of a 3.5 centimeter spherical applicator, and was administered intraoperatively to the unsafe margin. And the patient's discharged home on the 11th day with a reasonable postoperative course, and got imaging, has been NED now for 87 months. Not that the intraop necessarily made a difference in that, but it was a successful treatment with intrabeam. And we started a phase 1 study. We're doing a phase 1 study of a 3x3 trial of using different doses just to make sure this is safe at the time of resection. So patients not getting neoadjuvant therapy, going straight to resection. We decided a 10, 15, and 20 gray prescribed with the surface of a flat applicator for patients with resectable pancreatic cancer, hoping to just make sure there was no unusual toxicities. I really like that too for a couple of reasons. One is that maybe there is an abscopal effect, maybe there is an inflammatory response at the time of surgery, just like breast, so this might really be important to treat the area at highest risk. And as you know, in pancreatic cancer, the most important thing probably is systemic therapy, so patients go from their surgery to get systemic therapy sometimes for months before we even consider getting radiation, so at least they've gotten some kind of local treatment relatively early. And I would say, this is the schema. The first patient we treated had a phenomenal response. The patient got treated, and unfortunately, on the final pathology, didn't have cancer. So the FNA was not correct, and I wasn't my patient. It was Dr. Thomas's patient, but no, and actually it was my patient. I did the intraop. So you go tell the patient you've got good news and bad news. So the good news seemed to outweigh the bad news. Yeah, we didn't really need to give you the treatment, but you don't have pancreatic cancer. So it worked phenomenally. So the primary objective is to determine the dose-limiting toxicity and maximum tolerated dose with low kilovoltage intraoperative radiation, and secondary, develop acute and chronic clinical toxicity profiles for the treatment modality, and determine disease outcomes. Because again, this is a new form of intraoperative radiation. It has a different depth dose, a different RBE. We don't really know what the toxicities are. I think it's important that we start collecting this data. Rectal cancer, a lot of data on using intraoperative radiation for rectal cancer. And I'm just going to show a couple of them. Intraoperative radiation for locally recurrent colorectal cancers in previously irradiated patients by Mayo. Combined modality therapy with intraop resulted in long-term local control and long-term survival in patients with locally advanced colorectal cancer. Again, these are always a hodgepodge of patients, so it's very hard to say how much the IORT helped. But maintaining local control in previously irradiated rectal cancer patients is an important thing. This is some of the MGH experience with intraoperative radiotherapy for locally advanced rectal or rectal sigmoid carcinoma. And the 5-year local control was 35% with a series of 49 patients with recurrent disease. Again, is that better than what it would have been? We have no real good randomized trials, but they're suggesting that intraop can help. Again, this is locally advanced following preoperative chemo and taking the patient to surgery and giving intraoperative radiation at the time of surgery. Pelvic control rate by doing preoperative chemo RT and then intraop was 92% of these patients that had a complete resection, compared to 33% of similar patients not treated with IORT. And it seems to be, again, something that can benefit if you can do it. This is if I'm unaware of this, I think this is the only publication for using intrabeam in colorectal cancer. And our colleagues from Cleveland Clinic, we're collaborating or beginning a registry study on collecting the data in rectal cancer. Again, this was using the intrabeam device as the treatment. It's a very big hodgepodge of patients, suggesting 3-year local control rate of 56%. I showed you some which was 30% or 37%, suggesting that this may be better than what was done in the past. And again, this is high dose rate. IORT is part of a management strategy for locally advanced. Again, a lot of data on this stuff. Again, suggesting that patients with locally advanced primary disease were treated with EBRT, chemosurgery, and IORT had improved outcomes, both overall survival and disease control in patients not treated with IORT. So there is a lot of data out there, and biologically it makes a lot of sense. And the IntraBeam device, we've done 2 or 3 cases in the same day by rolling it between ORs. So it gives you some flexibility. And we used to send patients a lot up to Mayo because they have a nice intraoperative operating room, but our surgeons won't send anybody anywhere anymore in this day and age. So if we're going to do this, we're going to do it at our place, and I'm not going to get an accelerator with an operating room, for sure. I like it. So our experience. So we wanted to become a tertiary referral centers for effective salvage therapy. So we have gotten a fair amount of referrals because we have this and because we're willing to use it, because not many people in the city were doing it. So we decided to opt for the Zeiss IntraBeam and give 10 to 20 grade at the surface. Again, the mobile unit can be wheeled between different ORs. It does not increase a hospital stay, at least that's what we tell. You got to consent appropriately. That's the only thing I've run into. I've gotten called a couple times to say, hey, can you come do intraop? Can you wake the patient up? Once I did it by talking to the spouse, but it's very uncomfortable. So if you're thinking about it, have them see the patient before. It's always a better thing. Use the largest applicator you can. You can move the bowel. You can use lead shields. Good homeostasis. Confirm good contact with the surgical margin that you're treating. And Dr. Miller is going to present in a poster form that we retrospectively reviewed 9 of our patients we treated from 2014. With this prescribed dose, were varied between 5 and 10 grade to 0 to 0.5 depth, depending on whether they got previous radiation or were giving radiation again. We use both the flat and the spherical applicators in these patients. Survival at 2 years was about 90%, and there's a suggestion that the local control was reasonable. It's 9 patients, doesn't necessarily mean much, but it is, not that your poster doesn't mean much, but it is, it is some data. And this was our first case. It's Sam Pappas, who's left the institution. We got referred this before we got the IntraBeam because it was a locally recurrent rectal cancer. And that's me saying, I think we treated here, right? And we gave 10 grade at the surface and some postoperative retreatment. Patient unfortunately passed away from the metastatic disease, but the local area remained NED. Gynecological cancer, there's a fair amount of data with this too. I've used this in about 10 gynecological cases. You can use it for salvage of pelvic relapses. I haven't used it for vulvoperitoneal relapses, for R1, R2 resections, inflammatory bowel disease, or connective tissue disease. What I've used it for almost entirely has been very difficult nodal recurrences where the surgeon is peeling it off the vessels. I'm getting intraop and then given chemo-RT afterwards. And this is just, again, some of the data that shows that people have used IORT for locally advanced gynecological malignancies at different institutions. Again, these are hodgepodges of data. 5-year local control in this series was 67%, and within the IORT was 81% with very advanced disease. 5-year overall survival was 30%. Reasonable to us, again, a hodgepodge of patients. But again, first principle is oncology. If you don't control the disease, they're not going to do very well. And this is long-term. Another data from the group at Stanford looking at using intraoperative radiation for recurrent gynecological malignancies. Again, suggesting that a local control rate of 44% is not bad for recurrent bad disease in the pelvis with gynecological malignancies. So to kind of conclude kind of that half of my talk, there's many abdominal pelvic malignancies are associated with poor control. We know that. So I think there's a role for this in locally advanced setting. What we do at our institution, we have a lot of multidisciplinary tumor boards. And when we talk, simply say, do you think you're going to have an R1 or R2 resection? I could be available. Let me see the patient and we'll consent the patient. There's a strong suggestion in the literature that IORT can improve outcomes. There's never going to be a randomized trial. Because if I thought I needed IORT, I'm not going to randomize them to not treating. So I think for these where we're adding it to conventional therapy, it's just going to be experiential. And IntraBeam provides an opportunity to deliver IORT for a wide variety of malignancies without significant construction costs of an OR, an ability to treat multiple ORs the same day, no shielding. I think it's a practical way for your institution, especially if you're a tertiary care center, to have some options for these patients, because the options before wouldn't do IORT. That was the option. We'll do pre-op, we'll do something else, or try catheters, although they don't work very well. And I do want to thank Chelsea Miller, who helped put together a lot of these slides.